So today's class is going to be about refractive lens exchange in short eyes or in eyes with high hyperopia, which is axial high hyperopia. First, we have to describe the complex anatomical differentiation which needs to be done. We don't necessarily label all eyes as microphthalmos or nanophthalmos. There is a clear distinction in between them. So a short eye is can be defined as an axial length which is more than two standard deviations smaller than normal for the age group. And for adults, epidemiological studies have shown that it is around less than 21 mm. So there is a whole spectrum of eyes with axial length shorter than 21 mm. The most simple one being simple microphthalmos, in which only there is short axial length due to global eye reduction with no other findings. That is, the eye is symmetrically short. In complex microphthalmos, in addition to that, we can have colobomas, persistent fetal vasculature, and retinal dysplasia. In relative anterior microphthalmos, the short axial length is due to mainly the reduced anterior chamber dimension only, with normal posterior segment dimension and normal scleral thickness. In posterior microphthalmos, the short axial length is due to reduced posterior segment dimensions with normal anterior chamber dimensions. And in nanophthalmos, which is a special case, the short axial length is due to small anterior and posterior segments with a thickened choroid and sclera with a normal lens volume. So the lens is thicker as compared to the eyeball. So when we consider surgery in such short eyes, there are a few pre-op comorbidities that we need to know. The most important being occludable angles, which we can see on slit lamp, and then further we can evaluate them using gonioscopy, ASOCT, and UBM. And it has been known that biometric measurements such as a reduced anterior chamber depth, increased length thickness, and a shorter axial length have all been correlated with a risk of angle closure glaucoma. Shorter eyes also have a higher risk of Fuchs endothelial dystrophy. So, endothelial cell counts, central corneal pachymetry, and careful slit lamp examination should be done to document pre-existing corneal disease. Like I mentioned before, in complex microphthalmos, we can also have iris or retinochoroidal colobomas, for which we can do a B scan or IDO, which can help identify colobomas. In eyes with complex microphthalmos, we can also note a few cases which can have anterior segment dysgenesis. And an important thing to note on the B scan is to check for the scleral thickness and preoperative uveal effusion, if any. Coming to a very important aspect of calculation of IOL powers in small eyes, the first step is biometry. Here we need to note that a small error in axial length measurement will result in a larger refractive error in a patient with a small eye. So how do we measure this axial length? The axial length measurement can be done by using IOL master or LensStar. The IOL master is based on the principle of partial coherence interferometry, whereas the LensStar is based on optical low coherence reflectometry. The advantages of doing an optical biometry with IOL master or LensStar are that they are capable of producing reproducible measurements to an error of within 0.02 mm, which has been shown in studies to be fivefold better than ultrasound biometry. The other advantage being that it also gives accurate measurements of lens thickness, anterior chamber depth, and wide to wide. In many studies, IOL master and LensStar have been deemed as biometrically equivalent, so we can do either of them. Another important part to know that in high power IOL ranges, that is more than plus 30 diopters, which are very often required in highly hyperopic eyes, the true dioptric power of the IOL may vary as much as plus or minus 1 diopters according to the manufacturing standards of International Organization of Standards. So what they mean to say is if we are making say an IOL of 30 diopters, on the pack it will be printed as 30 diopters, but the true dioptric power may be between 29 to 31 diopters, and it is this range is still considered as tolerable according to the manufacturing standards of IOLs. After biometry, we come to IOL power calculation. which is based on keratometry, axial length, and effective lens position. So in eyes with a long axial length, the effective lens position is not as critical because of two reasons. One being the small IOL movement in the anterior posterior dimension, coupled with the low powered IOL, which is used in axial myopic eyes. So these 2 points, even if there is a change in them, it alters the final refractive outcome only slightly. In shorter eyes, the IOL power is typically higher, and even a slight change in the effective lens position can have a significant effect on the refractive results. Hence, it is crucial that we get a good biometry reading, especially having accurate axial length measurements. In IOL power calculation, Holiday et al. Have shown they have conducted a study to see the relative size of anterior chamber compared with axial length. So they have made this grid 3 by 3 grid, and in that study they have discovered that about 20% of the eyes with short axial length had a small anterior segment and were classified as nanophthalmic. The remaining overwhelming majority of the cases of short axial length, that is the 80% of the cases of short axial length, still had a normal sized anterior segment. Another thing to note is that the closer the IOL is to the retina, the more a small change in effective lens position will alter the refractive results. So in a long eye, where the distance between the lens IOL and the retina is longer, a small change in effective lens power is not going to produce that much change in the refractive results. However, in a short eye, where the IOL is placed closer to the retina, even a small change in the effective lens position is going to alter the refractive results drastically. The A constant, which is used in IOL power calculations, depends on many factors, including the type of IOL used, the refractive index of the material, the geometry of the IOL, the variance of biometric equipment, and the surgical technique. Hence, it has been suggested for small eyes with short axial lens, it may be best to have a personalized A constant separately only for eyes with short axial length. Coming to IOL power formulae, the best IOL power calculation formulas for small eyes are those that will effectively predict the effective lens position more accurately. In third generation formulae, they use only two input variables, that is the keratometry reading, corneal curvature, and the axial length to determine the effective lens position. Of the third generation formulae, Hoffer Q tends to be the most accurate when axial length is shorter than 22 mm. The fourth generation formulae use multiple input variables in addition to keratometry and axial length. For example, in Hage's formula, we require the anterior chamber depth. The Holiday 2 formula requires anterior chamber depth as well as white to white, lens thickness, pre-op refraction, and age. So these fourth generation formulas in addition to Hoffer Q are preferred when doing IOL power calculations in small eyes. A recent study conducted by Karefi et al. In 2015 has confirmed the superiority of both Hoffer Q, Holiday 2, and Hages over the traditional formulae SRK2 and SRKT. Even after that, a few meta-analyses have been done. In 2018, Wang et al. Have conducted a meta-analysis of 10 studies studying the IOL formula accuracy in axial hyperopia, and they have shown that Hage's formula was superior to Hoffer Q, Holiday 1, and SRK-T, but they have not commented on the accuracy of Hage's vis-a-vis Holiday 2 because the sample size was small. In 2019 and 2020, a few studies have shown that the Kane formula is superior to the traditional Olsen, Barrett, and Hill RBF Holiday 2 formulae. They have also shown that the E-metropia verifying optical EVO2 formula is also accurate in axial lengths of less than 22 mm. A recent meta-analysis done by Srivatsava et al. Published in IGO in 2022, they have included 15 studies, including over 2000 eyes, and 11 IOL calculation formulae, and they have concluded that although the lowest mean absolute refractive error and the median absolute refractive error were found for Barrett Universal 2, that is, the post-op refractive error was the lowest with Barrett Universal 2. The highest percentages of eyes within plus minus 0.5 and 1 diopters of target refraction was found for Holiday 1 and Hill RBF. So they have said that Barrett Universal 2 and Hill RBF and Holiday 1 also are good, but they have concluded that none of the 11 formulae that they have used, none of the formulae was found to be statistically superior over the other in eyes with short axial length.
What's the difference between Holiday 1 and 2?
In Holiday 2, I think there is a Cox adjustment needs to be made for Holiday 2, sir. There is a Cox
For long
factor
eyes.
which needs to be, yes, sir.
Long Cox, this thing, no?
Yes, sir.
Factor.
Yes, sir. Yes, sir.
Is that required for Holiday 2 or Holiday 1?
So that is required for Holiday 1. If we want to
Holiday
use
2, you
it
don't
for,
need it.
no, sir.
Right. So then I'm wondering why Holiday 1 was superior, not Holiday 2, in a study which is done so recently.
Yes, sir.
You said that this is a 2022 study.
Yes, sir. Yes, sir.
Can you go through it in more detail and find out whether they compared both Holiday 1 and 2 or they just used Holiday 1 for some reason?
Sure, sir. I'll read more into it, sir.
Also, for this other finding that you have said about Kane and Evo formula being superior to RBF and Olson and Barrett, is there this thing? The study is basically you're saying they're number 2 and 3. So 2 is basically by Mellis and Kane, and so Olson and Chang. Okay, so Olson is also part of that study, and number 3 study is also Kane is there in that. So the Evo formula comes out of Singapore basically, and Pham Hen Boer is the guy who's behind the Evo formula along with this, and Kane is, I'm not sure where Kane is, but these are two very good formulas. But I think, when we go towards the last part of your presentation, we will see that whether Kane did a good job in our patient or not. Let's go ahead.
Yes, sir. A few points about effective lens position. So a mathematical equation can be made to calculate the effective lens position and its relationship with the change in refraction. So according to the formula, we can see that it is highly dependent on the squared value of the IOL power, which means that in high hyperopes, usually we have very high IOL powers, and if IOL powers are higher, the chance of having a refractive surprise is much higher. In this graph, we can see the refractive change for every 1 mm increase in the effective lens position. So if effective lens position increases from around, if the IOL goes from around 20 diopters to 35 diopters, there is a change of around from 1 diopter change to 2.5 diopters change. So normally if we were to implant an IOL of say around 20 to 25, which is a normal range of IOLs which we can put for most people, the dioptric change because of the effective lens position is around 1 to 1.4, 1.5 diopters. However, in IOLs which have a higher dioptric power, more than 30, with the small error in effective lens position, the dioptric refractive change is going to be significant. That is the importance of having a good calculation of effective lens position, which in turn means that we need to use better formulae which do a better job at calculating the effective lens position. Similarly,
so Pranav, which are the formulas which are using these 5 or 6 variables? Can you tell me?
yes, sir. So Holiday 2 uses that. Apart from that, Kane, Olsen, Hill RBF, Barrett Universal 2 also uses it. There is also a new formula in the works, which is the LEDAS Super Formula, which has been made consisting of five formulae, and essentially it is a it is also a regression based formula, and it is based on real life uh, outcomes of patients, but it also takes into account five separate formulas and integrates the best parts of all the formulae and tailor makes the IOL power for each eye.
So Super Ladas also uses artificial intelligence other than Hill RBF. So basically, Super Ladas uses the regular formulas, but then it uses artificial intelligence and it uses inputs from all across the world. All right. So
Yes,
people
sir.
are people can tie up with Super Ladas and they can keep sending in their results and their outcomes based on PARs, and it keeps improving based on inputs coming from everywhere. Right.
Yes, sir.
Just like the Aura also does that. So Aura also kind of is connected to an international server where your results are also used for prediction of alpha. So Superladders is being it is being pushed by Uday Devgan, and
Yes, sir. Yes, sir.
Hill Hill RBFC when it started off, it was not taking all these five variables. It was taking only three. Okay, so there was a Hill RBF one, then there was a Hill RBF two, and there was a Hill RBF three now. The Hill RBF three has included white to white and AC depth as well. So anyway, what I wanted from you was which is the formula which we are using most often in our clinic.
So Barrett's Universal 2K.
So what all does Barrett's Universal 2 include? I mean, for what all do we input into the Barrett's Universal 2?
So we enter the keratometry, axial length, and the anterior chamber depth, sir, if I'm not wrong. We use only three variables.
Are you sure?
I'm not sure, sir, but I don't remember putting any other. I don't remember putting lens thickness or the white to white.
Okay, so actually Barrett's in the full form, it will work with just the three variables, but in the full form, it works with all the five. And that is the advantage of optical biometry over other things because our optical biometers can take AC depth and the lens thickness also along with the white to white. And these three variables, when added, will give more accuracy to the Barrett's, right? And all our biometers are using all of these. Okay.
Yes, sir.
So that is the advantage of our current Barrett's that we use, that it uses all these five variables when we do a Barrett's calculation. However, we are not really using Hill RBF much, which even though it is one of the most accurate. So somehow I feel that, tomorrow when you go back, you can add Hill RBF to the Barrett's too, at least for the Techness lens, which we end up using most often, so that we get an indication if there's a difference between the two. We used to have it before. Now, for some reason, our biometry staff has made everything to Barrett's only, you know, and there's no point, having so many biometers and then using only one formula when we have access to so many. For example, we should even use Haggis, which is there on the ILMaster 700. We can also use the, some of the one or two of the other formulas to get a better idea of, what all we are missing. So I think we'll have to kind of do that. Okay. So
Yes,
let's
sir.
go ahead.
So after having done the biometry and used the proper IOL calculation formula, we come to the selection of the IOLs itself. So Acrisoft SA6080 made by Alcon is a single piece hydrophobic acrylic IOL that comes in powers of up to 40 diopters. So it is preferable that when possible, we implant a single plus 40 diopter IOL rather than attempt polypseudophakia with two plus 20 diopter IOLs. If an IOL power of more than 40 diopters is needed, we can put an IOL of maximum power available in the bag, and additionally use contact lenses, glasses, or do laser vision correction for the residual power, or use a piggyback lens. So coming to piggyback IOLs, it is the primary placement of two IOLs in the capsular bag, one in the bag and one in the sulcus, and it has been associated. The disadvantage of putting two IOLs in the bag is that it is associated with significant interlenticular membranes and opacifications. It also has reduced visual acuity and a late hyperopic shift. It is also known as red rock syndrome. The interlenticular membranes are difficult to address with an Nd:YAG laser, and an additional intraocular surgery is often required to clear this opacification. So the preferred technique nowadays is to put one IOL in the back and one in the sulcus. So an acrylic IOL, that is either a single piece or a three piece, is to be put in the capsular bag. A three-piece silicone IOL is preferred to be put in the ciliary sulcus with the haptics at 90 degrees from the bag IOL haptics. The sulcus-based IOL ideally should be a three-piece design with angulated haptics and a rounded edge. That is, the anterior edge should be rounded to minimize damage to the posterior surface of the iris. If the sulcus IOL scrapes the back of the iris, it can result in pigment dispersion, iris transillumination defects, and even UGH syndrome. So there are a few options available, which is the AQ 2010 by Star Surgical, Sensar by Abbott, LI61 by Bausch and Lomb, and the Sulcoflex, which is made by Rayner, which is a single piece hydrophilic acrylic IOL with a 6.5 mm optic that has a posterior concave surface and undulating haptics with a 10-degree posterior angulation made especially for sulcus placement. So coming on to the issue of whether to put the piggyback IOL in the same sitting or do we prefer two sittings? So we prefer two sittings because better IOL power calculation is possible based on the residual error. Therefore, in first sitting, we put the IOL in the bag. In the second sitting, we do an accurate IOL power calculation and estimation of the space available to us in the sulcus. In piggyback IOL calculation, we can use the refractive versions calculation with the Holiday IOL consultant, or it can be estimated using Gills or Nichamin monogram. In the nomogram, it is a simple method which determines the residual refractive error, and it basically multiplies it by 1.5 for a hyperopic error. So for an example, if 2 diopters of residual refractive error is there following the primary surgery, so 2 into 1.5, which is plus 3 diopters, sulcus IOL needs to be placed. So we have to be very careful during the primary surgery, and every measure should be taken to protect the capsular bag during the phaco, because options for alternate IOL fixation are limited because there may not be sufficient room for an AC IOL, and if the primary lens itself must be placed in the sulcus, there will likely not be room for a piggyback IOL. So surgeons should learn from the first eye and use that data to hone the IOL calculations for the second eye. And as long as both eyes have similar preoperative biometric readings, they are likely to have the same final effective lens position. So on the basis of the refractive outcome of the first surgery, we can tweak and modify our calculations for the second eye, because as long as both of them have similar biometric readings, the final effective lens position, which we now know because one eye is pseudophakic, is going to be more accurate. Coming to surgical issues which we face during operating on small eyes. Firstly, small eyes may be mostly deep set, hence a temporal approach is better than the superior approach, just for ease of instrumentation. And the additional advantage of having a temporal approach is that the horizontal white to white is bigger, so we'll have more space for manipulation. Preoperatively, we need to check if the patient needs a YAG-PI and control their IOP. For anesthesia, if we give a local anesthesia, it will definitely bring the eye up, but it can cause upthrust and vortex vein congestion, leading to an increased risk of uveal effusion. So we prefer topical anesthesia. If the patient has pre-existing effusion, then we treat medically with steroids and cycloplegics and then operate. Coming to intra-op issues, previously we needed scleral windows for uveal effusion when we were performing ECCE, but nowadays with phacoemulsification, it is a closed chamber surgery and there are lesser fluctuations. So we have felt a lesser need of doing scleral windows. If uveal effusions develop in an anophthalmic eye during phaco, it may be necessary to perform inferior sclerotomies to soften the eye and to complete the procedure. The working space is already less, so to increase our working space, we can give preoperative IV mannitol and preoperative gentle massage to reduce positive pressure on upthrust. Even the side ports are of utmost importance. It has been noted that the corneal pachymetry is slightly thicker than average in short eyes, and if one uses the same angle of entry as with a standard incision, the tunnel length may be longer than anticipated with a more anterior internal entry. So this anterior internal entry can make it more difficult to access the lens in an already small space. Another issue is that the pupillary dilatation in small eyes has been found to be insufficient and suboptimal. So to expand the pupil, we would prefer iris hooks over say Behex ring or a Malyugin ring because already the working space is limited. In OVDs, we can use a cohesive OVD, especially in the initial steps of the surgery because it creates space and flattens the convex anterior lenticular space anterior lenticular surface. For the phacoemulsification part, we can do a soft shell technique. So this OVD is going to help us have an easier manipulation and a better rhexis creation. And rhexis creation would be better if made from the side port rather than the main port to avoid shallowing of the AC. Another intraop event which may occur is because of the shallow and small AC, the iris is closer to the lips of the incision and hence has a greater risk of prolapse. So we have to have a greater control over fluidics and have a watertight incisions in order to operate with lowest fluidics possible. Also, we need to avoid fluctuations in the AC to prevent intraoperative suprachoroidal hemorrhage and uveal effusion. Sir, ma'am, any comments regarding the surgical issues?
So in fact, I think I see Dr. Das is there. He's the best person to actually tell us about the problems from the retina point of view that we should be careful about because, these high hyperopic eyes and nanophthalmic eyes, I don't know if they have any experience with any of these, the sclerotomies required or uveal effusions or anything. Dr. Das, do you have any thoughts?
So we need to see whether there is any pre-existing choroidals. Many of these cases, they already have some sort of choroidal elevation and a little bit of big swelling, even pre-operatively, because those eyes are most likely to develop frank uveal effusion and exudative detachment post-operatively.
In fact, I remember there was one patient which we were working up for surgery who was showing an IL power of almost plus 70. And he had I think if I remember correctly, his exit length was like 15 or 16 diopters. Eventually, we did not operate that patient. But I think we had referred to you for B-scan, and we have to check for the choroidal thickness basically on B-scan. And you guys had actually done that. And that is one of the most important things to look for in those very, very small eyes, that what is the choroidal thickness, because that can help you kind of predict whether you are likely to face issues. So in fact, I don't know who had presented that case. Maybe Tulsi Priya had presented that particular patient in one of the classes also. And we will have data of that patient. Right.
Choroidal thickness was significantly high. Our B-scan, it is usually RC thickness around 1.5, but that was, I think, as far as I remember, it is around 2.7 or 2.8.
My only concern is that, if you're doing a very short eye like that, should you do like preventive sclerotomies to begin with, or you should do it intraoperatively, or what? I mean, how to decide? That's something which I would love to hear if anybody would like to say anything on that.
So preoperative assessment will be very, very important. If there is this thing pre-existing shallow choroidals in the periphery, then the eyes are very likely to develop it immediate post-op or intraop. But sir, doing sclerectomy, then it's quite invasive actually. You have to tag all the 4 rectus muscle and you have to just go towards the vortex in each quadrant and just enter to the vortex. You have to do around 4.5 to 3.1 mm partial thickness sclerectomy. So
also in that case, I know. So I'm also thinking, because see, Pranav was trying to tell us that, a topical anesthesia may be preferred, but suppose you end up in a situation where you require intraoperative there's an effusion, and then you are into a situation with, sudden upthrust and shallowing of the chamber and all that, hardening of the eye. You may need, regional anesthesia for peribulbar anesthesia to do all those things that are required. So and on the other hand, if you start with something like peribulbar, you are already creating a situation where that kind of a situation may develop. So I don't know which is the better way to approach. Anybody else also wants to comment, please tell us. Dr. Das can also tell us whatever he thinks is right.
Mostly, actually, sir, these eyes, the orbits are also a little shrunken, I believe.
Yes.
Orbital volume is also less. Already,
Yes.
the venous outflow is quite restricted, and if you put fluid, then there's a problem, actually. There will be a problem, but I don't know, means people also do not dilate fairly well in this case, in these cases.
Absolutely. In fact, we had, I don't know if Shitu remembers this, we had prepared a video. Was it Shitu who had prepared, or I'm not sure. Last year, we had a patient who was a very high hyperop, and we were doing a refractive lens exchange. And for some funny reason, we decided to do a femto, luckily. I had 5 femtos that day, and this patient was done as a second or third patient. And after that, we did 2 more, and then I operated 2-3 patients, and then his turn came. So by the time he came to the OT, he's a young man of about 35. And by the time he came to the OT, his pupil was just about 3 to 4 mm, whereas on the femto table, it was like proper 7-8 mm. So I didn't know what went wrong, because none of the other patients had a problem. And it was a very, very challenging surgery with significant upthrust and all during surgery, but I had no choice. Luckily, it got completed, and we were able to complete it. But then we anticipated that in the second eye, same problem will be there. So for the second eye, what we did was we gave him Dimox and all. And we also kept him as the last femto case and the first one to go into the OT. And in spite of all that effort, we still had a situation where the pupil came down very fast in the second eye. We've made videos of that, and I think we presented it last time somewhere. I can't remember where I presented it. But these are the other things that, suddenly your pupil can come down, and you're already dealing with an eye which is very small. The IOL is very thick and big. So lots of challenges, and, it can be a difficult situation. So any other things that anybody has encountered? Dr. Mrinal is there, Dr. Amardeep is there, Dr. Ruchika is there. Have you encountered any other things with these high hyperopic eyes that you would like to discuss?
Sir, positive pressure, definitely we have encountered in many cases.
Absolutely.
Hello?
Yes,
Sure. Yes.
And sir, but what would you do preoperatively? Would you give mannitol or Dimox or what?
Sir, if it is a colobomatous eye, I prefer to give a tablet Dimox before surgery.
Right.
And is there any role of subtenance block instead of a peribulbar if we have to use iris hooks or capsular bag hooks for some reason?
I don't know. I would somehow personally want to use topical anesthesia only. Somehow I find it difficult to operate. I have received a peribulbar for some reason. The whole dynamics changes, and I think topical is much better for me, and intracameral works better.
Instead of peribulbar, subtenance blocks.
Yeah, I don't know. I'm not sure. Somebody else can comment, I think.
Subtenon might create more problem, madam. Because the scleral thickness is very, very significantly altered in this sort of cases, and they keep on compressing the vortex. So definitely, even if we give subtenon, if it goes posteriorly, probably it will have more, kind of a crowding kind of situation at the exit of the vortex. So that may be a problem, I believe.
So in case we have to give a block, it should be peribulbar.
Very, very minimal, 3-4 cc of block maybe, and give good massage.
Sure.
And probably intracameral.
Sure.
Because I believe the globe becomes very tense once we enter the AC. Probably sir can tell a little bit. Somehow the globe becomes very hard once it is instruments are inside.
Absolutely. Yes, absolutely. Perfect. Chalo, let's see more. He has more interesting things to say. So let's carry on.
Sir, just a disclaimer, the meeting might end anytime, so I have forwarded the part 2 link also. So once this meeting ends, we can all join in that link. Coming to post-operative issues, the main one being a residual refractive error, and various studies have shown that residual refractive error following cataract surgery in small eyes tends to be. So the main post-operative issue being a residual refractive error, and studies have shown that this residual refractive error tends to be towards hyperopia. A study conducted by Jung et al. Have shown that in nanophthalmic eyes, only around 46 to 66% of the eyes achieve within one diopter of the aim refractive error. In microphthalmic eyes, it is slightly better from around 65 to 72%, and in normal eyes, we achieve around 90 to 98% of cases within one diopter of the aim. Another post-op issue known to occur in small eyes is the higher post-operative inflammation. Another important one being the raised intraocular pressure in the post-operative period, especially due to secondary angle closure due to either uveal effusion or aqueous misdirection. So to differentiate between them, we can do a UBM or a EB scan. Uveal effusion up to 9.3% have been noted in studies, and especially it is noted when there is a sudden decrease in intraoperatively IOP intraoperatively. Also, the abnormalities of the sclera and increased resistance to transscleral fluid outflow, in which case subscleral sclerectomy may be an effective treatment. So uveal effusion of around rate of uveal effusion of around 10% has been noted in studies. Coming to a very interesting case of a refractive surprise. In our OPD, we saw a 38-year-old male who wanted freedom from spectacles for both distance and near. His current glass prescription was plus 5.75 with plus 1.75 diopters, cylinder at 142 degrees in the right eye. In the left eye, he was wearing a plus 5.25 diopter sphere plus 1.25 diopter cylinder at 41 degrees. With pinhole, with the right eye, he was improving to 6.9. With the left eye, he was improving only to 6.18. On the autorefractometer, we have seen that in the right eye, his readings were plus 7.75 with a plus 1.5 cylinder at 176 in the right eye. In the left eye, plus 7.75 sphere with a 1.25 diopters cylinder at 2 degrees. In the acceptance, we have also noted an add of plus 1 diopters in both the eyes, and also to note in the left eye, he reached only N10. So left eye was amblyopic. The external exam, pupillary examination, anterior segment, intraocular pressure, and posterior segment examination all were within normal limits. Okay. So coming to the IOL power calculation that we have done for this patient, I will take you through our thought process, and I am sharing actual photos of the calculations that we have done and how we have improved it for the second eye. So in the first eye on the lens star, uh, as I mentioned before, we were going to use the Acrisoft by Alcon SA6080, which gives a power of up to 40 diopters. So that was our lens of choice. In the right eye, we can see that the axial length is 20.25 mm with a central corneal thickness of about 566 microns. Anterior chamber depth was 2.8 and a lens thickness of 4.19. So lens was very thick. Using the Barrett's formula with a target refraction of emetropia, we were getting around 38.5 for minus 0.43 and 39 diopters lens for minus 0.82 post-operative refractive outcome. Using the short eye template on the lens star, which uses the Hoffer Q formula, we were similarly getting around 37.5 and 37 diopter lens suggestions. On the IOL master, unfortunately, we did not do the calculation for the SA6080. Similarly, but the biometric data was similar to what we have seen with the lens star. And the white to white was also normal in this patient. The Anterion used the SRK-T formula, which gave us a prediction of 35 diopters of IOL power. So eventually, considering all this in the right eye, which we operated first, we used the 39 diopter lens. On the first post-op day, we had a myopic refractive surprise, and by day 14, the refraction had stabilized to around minus 3.25 diopter sphere with a minus 0.5 diopter cylinder at 117. His uncorrected visual acuity in that eye was 660, and with pinhole was only improving to 612, and the central fundus was normal. So in view of this refractive surprise in the right eye, for the left eye, we were more cautious. So we used multiple formulae. In the lens star, we can see the biometric measurements of a very short axial length, a thick cornea, a very shallow anterior chamber, and a thick lens. Here we calculated the IOL power for the desired IOL, that is the SA6080 with all the formulae. So with Hoffer Q, we were getting around 37 diopters suggestion. With the Hill RBF, again, we were getting around 37 diopters. With the Barrett's, we were getting 38 diopters. The Barrett Universal 2 on the Anterion gave us a suggestion of around 39 diopters. And also the IOL Master using the Barrett Universal 2 gave us a suggestion of around 39 diopters. So since we already had a refractive surprise in the other eye, we chose to go with a 37 diopter lens. And on the post-operative day 1, the patient had a AR reading of plus 0.25 with a plus 1.25 SIL at 173 degrees and an uncorrected visual acuity of 618, which was the highest potential because it was an amblyopic eye. So just for interest purpose, I tried and calculated two more formulae which the studies have suggested, which is the Kane and the EVO formula. According to the Kane formula, we should have used the 37 diopter lens in the right eye and the 36 diopter lens in the left eye. Whereas according to the EVO formula, in the right eye, we should have used the 36.5 diopter lens and in the left eye, a 36 diopter lens. Sir, your comments, sir.
Yeah, so so a lot of things here. First thing is that if you look at the right eye calculations initially, the lens star was telling 38 on the for the SA60, isn't it? 38.
Yes,
And
sir.
for the technice, it was predicting 39. If you look at the bottom, and
Yes, sir.
for this was with the Barrett's. For some reason, we have done Hoffer Q for various lenses which are not even available. So there's no sense. This
Yes,
is
sir.
what happens so often that, like if you look at there, we have done Vivinex and CT Asfina and Acris of MA60 AC. We don't even get those lenses, even the Technics for that matter. So it would have been better to just have calculations all for the SA60 and for with the various formulas. First thing, we've made a mistake over there. On the other hand, if you look at the in the right on the right side of the screen here, this is done with the I think Hoffer Q, which is suggesting 37, right? So 37 according to the Hoffer Q, and the Barrett is suggesting a 38 for Plano outcome.
Yes, sir.
Now the thing is that as you had also spoken in your talk, that you tend to get a hyperopic surprise, and even in my experience with most of these times, we have kind of ended up, in spite of using the Barrett's or the Hill RBF, we have ended up with a small hyperopic surprise invariably. All right. So I was actually tempted. If you notice, I've marked out first 38. I thought I'll use 38.5 to get a little bit myopic because I was worried about a hyperopic surprise, and patient is already in the presbyopic age group. I was wanting that if at all I get a small surprise, it should be on the 0.5 to half to 0.75 diopter myopic rather than plain, I mean, a hyperopic surprise. So that is why I first marked 38.5 actually. Okay, I had decided to use a 38.5 lens, but then our staff got back that they don't make 38.5. Either they will make only 38 or 39. Okay, so we had gone with the 39 instead of the 38, because with 38 I was little worried that I might end up getting a small hyperopic surprise of maybe half to 1 diopter based on this. So we had gone with 39 thinking that we might get if at all, we'll get a myopic surprise of maybe 0.5 to 0.75, which is acceptable. So I don't understand why we ended up getting a 3 diopters of myopic refractive surprise, because if you look, even if we had used a 37 diopter lens, according to this, we would still have been just 0.73 hyperopic. So that means the difference is almost between 39 and 37 is 1.5 diopters, right? So
Yes,
even if
sir.
we had gone with, frankly, had we gone with 38, we would have got only 0.8 less myopic surprise,
Yes, sir.
isn't it?
Yes, sir.
And if we had gone with the Kane formula in this case, which was suggesting 36.5, for example, right?
Yes, sir.
Huh?
Yes, sir.
Or we had
36.5.
gone with the Evo. Can you take us to the Evo screen?
Yes, sir.
So Evo is also suggesting 36.5, right?
Yes, sir.
Now, if we had gone with that 36.5, maybe we would have still been 1 diopter myopic, because if you notice, 37, now you can go back to that initial screen. With 37, we were going to be 1.5 diopters less than with 39, isn't it?
Yes, sir. Yes, sir.
So that means that instead of 3, we would have been minus 1.5. And with 36.5, we would have probably been about minus 1 or something. So can you see the situation? I mean, we still don't know why, in spite of, having all these parameters, they're fluctuating all the way from 38.5 to 36.5. But if any lens we had used, we would have still got a myopic surprise. So there's definitely something funny about this eye, because most often I've always ended up getting a small hyperopic surprise of about 0.5 to 0.75. That is why I ended up using 39 instead of 38, because I wanted to actually use 38.5. Now look at the other eye. Other eye, it is absolutely different. See, we went with a 37 as per prediction. I mean, if you notice, all these formulas are suggesting somewhere around 37 only, except the Al Master with the Barrett's, which is giving 38. Or sorry, even 39, frankly. So it is suggesting 39 on the extreme right bottom. Now the problem is that we used 37 and we have got a slightly hyperopic surprise, right?
Yes, sir.
And if you look at the Kane, if we are assuming that Kane is probably the best, or now see, Kane is suggesting that we should use 36. Okay, had we used 36 in the left eye, we would have got a hyperopic surprise of almost 1.5 diopters.
Yes,
Right
sir.
now, the patient is hyperopic by about. Right now, patient is with 37 diopters. Patient is hyperopic by about spherical equivalent of about 0.75.
Yes, sir.
Right? And had we gone with 36, it would have become 1.25 or something, or maybe 1.5 diopters. So here in the left eye, it seems Kane is not working well at all. It's working in the opposite direction. Whereas in the first eye, Kane seems to be the best of the lot, but in the left eye, it seems to be the worst of the lot. So I'm still not very sure what is correct and what is not, because this is such a difficult. Now, the only thing we can do is that when the patient comes next, we'll do an anterior, we'll check the ELP and use the
Sir.
ELP to back calculate that. Sorry?
Yes, sir. Sir, I was thinking that maybe in the right eye,
Uh,
because of very peripheral CDs, the lens iris diaphragm may have been shifted little bit forward and caused.
So that's exactly what I want to see. I want to do a post-op anterior for both eyes and look at the new AC depth and where the lens is sitting behind the cornea, how far it is sitting behind the cornea. And then we can try to see if there's a difference between the two eyes, why they are behaving differently. One eye got such a big myopic surprise, and the other eye has got a hyperopic surprise of a little bit, which is more like what we expect. So this is the story, but very interesting case. And frankly, even I don't have an answer. But if anybody else wants to comment here, looking at all this, I would love to hear from anybody else.
Maybe it's a little bit of ciliochoroidal effusion in the first eye.
So we can then, try to. So in that case, what you're saying is maybe correct. If there is some effusion of that kind in the first eye, that will cause the lens iris diaphragm to be pushed forward, at least temporarily.
Little bit forward.
Right, and that would account for the myopic surprise. Second possibility is that there may be a capsular distension syndrome. We should look for that. If there is a capsular distension syndrome, we may have the IOL pushed forward by the fluid or viscoelastic, which may be occupying the space behind the lens. So I think getting an anterior and then for both eyes would make a lot of difference from all these points of view, the ASOCT, and that would help us. Good thought, Dr. Das. I think you're right.
Yeah, even maybe OCT, and maybe I can have a look at the fundus.
And we should also do a dilated exam.
Yeah, even optos we can pick up.
Optos can be done. Yes, absolutely. Anybody else has any other thoughts?
The role of PI, sir. Should we do
sir.
PI in all cases?
No, I don't. No.
Okay.
But that's also
Sir,
something which has been. Yes.
So actually the Kane formula, do they take the lens thickness also in the consideration?
Yes,
I
yes,
think
ma'am.
so, but
I
I think
calculated today. So they have asked for
So
all,
Pranav, what?
ma'am, all
So
the.
here you have written the right eye lens thickness as 4.90, and the other places you have kept it as 4.19. The lens star one, if you can check the right eye, not the left eye.
Can you go back to the
Right
right
eye.
eye?
Right eye.
Yes, ma'am. You're right, ma'am.
So right eye is
4.19.
showing up as
Yeah.
on lens star it is showing as 4.19. On IL master it is showing as 4 point something. Can you see IL master? That's showing up as
4.46. Yeah, that is an error in my
4.46.
entry.
So
Yes, ma'am.
and also it is very different between the two eyes, and yours is totally different what your input. So I think
Yes,
that is
sir.
one more thing.
I was thinking, see, the IOL itself, it has a thickness, right? If higher power IOL are there, they are thicker than the lower power IOL. So the thickness of the IOL, does it affect the eventual refractive error? That is what I wanted to know.
Yes, ma'am.
Do you have
Actually,
any article?
ma'am, they have people. I mean, there is a discussion about this, about considering the eye as the cornea and a lens as a thin refracting unit, and then judging the effective lens position. So essentially, what we mean to say is thin lens optics, if we use, then we can get one power of IOL. But in reality, like you said, ma'am, the IOL should not be considered like a thin lens, nor should be the cornea. So it should be done according to thick lens optics. So the newer formulas which we use, they use all the thick lens optics calculations and then estimate the IOL power.
So I was just wondering, because rest of the things are okay, like apart from effective lens position, I think lens thickness has something to do with in this case.
Definitely. And in
IOL
fact,
lens,
Pranav,
IOL.
you had only. Yes, Dr. Meenal.
Yeah, the IOL thickness and the lens thickness, there must be some connection between the two, like how the lens is positioned, how much is the thickness of the IOL, and what was the thickness of the lens, the natural lens. I think that is the factor which is variable.
So thickness of the lens actually is already taken into account into the A constant.
Correct.
So that will not, because that we know that what will be the thickness of a lens of a particular power. So that is already incorporated into the formulas and the A constants which are used. But definitely the lens thickness which we have used in the formula here, and as Pranav had himself only said that, the biggest variable is ELP in short eyes. And by putting a
Correct.
lens thickness which is different from what it actually is, the half millimeter shift that he has shown, he has added half a millimeter, at least half or even more. I think 0.75 you have added to the lens thickness. That will shift your ELP by about 0.75 millimeter, Pranav. And if you go back to that slide, you'll notice that 1 change of thickness in this power was changing the IL power by 2 diopters.
Yes, sir. Yes, sir. But sir,
So I think you should.
the EVO formula is showing, I mean, I have entered all the details correctly in EVO
Correctly,
formula,
right? So
but still it
it'll
is
be
showing
interesting.
similar only.
Yeah, it'll be interesting. Tomorrow you do the cane with the new thing and post it on the group for everybody to see. Okay.
Yes, sir. Yes, sir.
Also,
Yes,
I
sir.
have a suggestion that please go back and do the Hill RBF for the right eye as well, because we've done it for the left eye, which showed up like something like 37, but we haven't done it for the right eye. We should also do the Hill RBF for the right eye and see what it was predicting. Okay.
Yes, sir. Yes, sir.
Because and then that will also help us, and maybe if we have a post-op uh, optical biometry done or anterior done for at least the right eye, we may have done it, because when we did the left eye biometry again, we might have got the right eye effective, I mean the AC depth. But I think when the patient comes for follow, we must do on that day the anterior, and maybe even on the Lenstar and Almaster 700, let's take readings to see and then analyze where we have gone wrong and what is the difference in the ELP of the two eyes, and then we can get an optos also done. That would answer many of our questions, I think.
Yes,
so.
sir. Sir,
Now
one
here
more.
I have a question. If we get
Sir, I had a doubt. Maybe because the dimensions of the eye are small and we are using an IOL which is meant for proportions of the normal eye, and maybe the bag is small, and that's why the lens haptics are tense and the IOL is being pushed forward in some way because of the bag being smaller.
no. See, a high-powered lens like this is obviously made for an axial length which is short.
Okay, sir.
It is already made. It's not made for a normal sized eye. I mean, when a normal sized eye would not need an IOL of this power anyway, right?
Yes, sir.
So I don't think that is valid. I don't think so. So, chalo, but very interesting. And if anybody else has any other thoughts, okay, you have some more slides.
हाँ sir, I got misplaced, but I wanted to close with this. So coming to RLE for young hyperopes and presbyopic hyperopes. So with laser vision correction, there is a high risk of regression and significant induction of higher order aberrations, which will lead to poor quality of vision. With phakic IOLs, there is a very high risk of glaucoma and uveitis and endothelial decompensation due to the shallow AC chamber depth, anterior chamber depth. With refractive lens exchange, if the patient is eligible for multifocal, then yes, he has freedom from glasses, but nighttime driving issues of glare and halo are significant, especially if you want to do it in young hyperopes. If the power is too high for a single multifocal IOL, then we can do a piggyback multifocal IOL, which is available with Sulcoflex. So, Sulcoflex multifocal IOL is available from around -3 to +3 diopter sphere with a +3.5 diopters near add. So that option also can be done. So the main IOL will be a monofocal IOL which will be placed in the bag, and the Sulcoflex multifocal IOL will be placed in the sulcus. There is an interesting study done by Ferrer Blasco et al., in which they have compared the contrast sensitivity with multifocal IOLs for especially high hyperopes who have undergone refractive lens exchange. In this, they have considered the diffractive multifocal IOL, which is the Acris of Restore IOL, and they have concluded that it yields good distance and near contrast sensitivity under photopic as well as mesopic conditions. Although they have seen that the mesopic contrast sensitivity was reduced at distance and near in relation to that found under photopic conditions, the performance was comparable to that before surgery with the natural lens, and that too with monofocal IOLs. So the issue of contrast sensitivity, especially with high hyperopes undergoing refractive lens exchange, they have shown that they have a good contrast sensitivity. And another interesting study done by Fernandez Vega et al. About monofocal plus or enhanced monofocal IOLs in high hyperopia for refractive lens exchange in high hyperopia. So there were two parts of their study. In the first part, they have compared three IOL powers, which is a plus 10 diopters, plus 20 diopters, and a plus 30 diopters. And the power mapping in their study revealed an increase in positive power from the periphery to the center of the lens, providing an extra positive correction of 1 diopters for a 2 mm pupil size. As the pupil size became smaller, there was an extension in the depth of focus effect, providing an extended depth of focus of up to minus 1.5 diopters for a 2 mm pupil size. And for 2 mm pupil size is basically the pupil size which we are going to have when we are going to be reading, because at during reading we are going to have good illumination, and also during reading we have the near accommodation reflex, which is also going to constrict the pupil. So 2 mm pupil size, which is ideal for near work and intermediate work. The depth of focus was excellent in high hyperopes, and there was no significant dependency of the IOL base power on the power profile, wavefront, or optical quality. So they have concluded that even if we use a very high plus lens, the optical quality of the lens was still comparable to the normal IOL powers. So in the end, they have concluded that the monofocal enhanced IOL provided good distance, optical, and visual quality, and optimal visual quality up to an intermediate near vision distance of around 50 to 40 centimeter in patients with high hyperopia and a short axial length. That was my presentation, sir.
You did a good job. You missed out on one option which can be done also for high hyperopia. Would you like to take a shot?
Sir, accommodating IOLs or light adjusted IOLs?
No. Yeah, LAL is there, but again, that won't make so much of a difference because that is also not available at such high power, I think. I'm not sure LAL kitne tak hai, but it's becoming very popular in the US right now. So, but that I'm trying to talk of something else.
No, sir, I can't think of anything.
So
Sir.
Philly is another option. Philly. Addition technology of lenticule to the cornea.
Oh. Epikeratofakia type, sir.
Yes, like that. Philly, which has been described, and for very high hyperopia, they have described Philly as a good option where you can actually correct up to 10 or 8 to 10 diopters of hyperopia with that. You implant something like a smile lenticule into the pocket, into the cornea, and induce a central steepening.
Okay, sir.
So anyway, but we are not doing it, so it's okay. But excellent class, and if anybody else has any final comments, then we can go on. But tomorrow, please post the Hill RBF for the right eye and also the corrected cane. And see if we have, I think we have Holiday 2 in the Virion machine. If we have Holiday 2 there, you can do the Holiday 2 also. And maybe if you want to do Haggis on the Master 700, that would be nice. Let's see what the different formulas are saying and make our own decisions about what worked best for us in this situation. And maybe tomorrow you can also do the ray tracing calculation on the Anterion that has the option to do ray tracing. Just do the ray tracing or using the Oculix formula.
Sure, sir.
Okay.
Yes, sir.
Let's see what comes out. And then after that, when the patient comes, please post us the analysis based on the ELP and the AC depth in the two eyes and why we may be having a myopic surprise in the first eye.
Yes, sir.
Okay?
Yes, sir. Yes, sir.
Okay. So any final comments from anybody else before we close? Chalo ji. Thank you, everybody. Good night. Thanks, Pranav. Good night.
Thank you, sir.
Okay.